gas for neighboring countries. It's a complicated subject. Again, we are talking the vertebral basilar circulation. It's a complicated subject for professionals on angioplasty, clinical neurologists, and vascular surgeons. So I'll try to elaborate on that a little. And the second issue, by the way, where is the pointer? Oh no, how to move the slides. And the second issue, I like actually the comment made by Professor Volodovs. There was a threat, there is still a threat, yeah, like a blacksmith area in active surgery or angioplasty. In fact, it's still important and will be significant. But again, so the collaboration between clinicians who in fact prescribe pharmaceuticals for treating stroke with surgeons who treat stroke surgically should take place. I have to tell you that in majority of guidelines, international guidelines, so we see very few data on vertebral basilar circulation. In fact, they read symptomatic obstructive disease of the vertebral area. It encountered less commonly, and it's less well understood. And we can tell that there's a data that about 20% of all strokes in the vertebral basilar circulation are the results of atherosclerosis of the vertebral artery. What's important here? We still arguing whether should we intervene in case of 50% stenosis. We have the data about 50% stenosis that causes stroke and recurrences of this particular lesion as opposed to carotid arteries. And again, the risk of stenosis is rather high, and it justifies our intervention. Who to treat? A few words about the brachiocephalic trunk and the subclavian arteries. The symptomatic ischemia is not as simple as it seems to be. It requires certain surgical approaches, but if it's too complicated, so we do transcutaneous angioplasty, but both approaches are legitimate, and should be at discretion of the surgeon. What else is an indication? That's why I'm showing you this. Asymptomatic patient with asymmetric blood pressure on the upper limbs, with retrograde blood flow in the vertebral arteries, should not undergo revascularization. Well, guidelines recommend. Just a few words about our Russian guidelines, and that in fact are very explicit about as far as the vertebral basilar circulation is concerned. As a neurologist, I must tell you that there are the indications based on the cerebral vascular insufficiency. Well, I mean, it's not a very clear definition, and it seems to me that this aspect in of the Russian guideline leaves much to be desired. It needs to be refined. Because again, it may be interpreted very differently. That's why, it interferes with our standardized approach. That's the same. Who to treat? Extracranial portions of the vertebral arteries, including patients with chronic insufficiency in the vertebral basilar circulation. Actually, they are not eligible except for like a single cases hypoaplasia of one vertebral artery or anatomical version of the circle of Villizi. And if there is no correlation between the focal lesion and symptoms, so we have to ask ourselves whether this stenosis is symptomatic, and it's very complicated to make this distinction as far as vertebral basilar circulation is concerned. It's difficult to evaluate again the symptoms of this particular stenosis. If we don't see the locus, the lesion, it's very difficult to link any symptom to this particular condition. That's why imaging, first and foremost, MRI, plays an important role, because we need to visualize, to see the site of ischemia, intracranial portions of the vertebral and basilar artery. And we just discussed it with Professor Cohen from Israel, who gained a great deal of experience of operating on intracranial vessels. I asked about asymptomatic stenosis. No, there are no indications. And even symptoms are somewhat conditional. Because if the stenosis is symptomatic, what are we concerned about? About, again, recurrences, repeated events. Maybe 6 months already elapsed with no recurrences. Do we have symptoms? Maybe. And what about 1 month, 1 year, 12 months? If nothing happened, and we have to reconsider the very notion of symptoms. And the second issue that can be lacunar stroke, in particular again the vertebral basilar circulation. And the majority of these lacunes are not to arterial hypertension, but it's a rather wall atherosclerosis with a development of lacunes, but there is no stenosis. It may be present at different site, but stenting here will not reduce the risk of lacunar stroke. Again, I wouldn't go ahead. How to treat this kind of patient? And as a neurologist, I have to tell you that we need to use pharmaceutical medications in order to prevent ischemic stroke. But it's standard. But in this context, I would like to mention that in the fall, the United States of America presented the data on lethality or mortality related to strokes. Now, stroke is the fourth leading cause of death after lung cancer. So patients in the United States, at least, die less frequently of stroke nowadays. But again, the same connotation. What does it mean for us in the real life? First of all, it means that all patients with a high risk, uh, at high risk of stroke or with history of stroke are indicated secondary prevention, which is not done all the time. But we keep discussing it at the European conferences devoted to stroke. Again, the pharmaceutical prevention emphasizes the necessity for the development of safer angiosurgical and endovascular interventions. So I believe we'll reconsider our approach in the near future. How to treat, again, extracranial portions of the vertebral arteries. According to the guideline, endovascular surgery is indicated, but more often, so we prefer endovascular surgery versus open surgery. One of the most recent textbooks on stroke, Marcus, Pereira, and Cloud. Endovascular angioplasty of extracranial portions of the vertebral arteries is safe and may be combined with other treatment modality. Okay, slowly but surely we're shifting emphasis from open surgery to angioplasty and stenting, even at the extracranial level. What's going on at the intracranial level? Of course, only angioplasty with stenting is feasible. Once again, I would like to stress that it's important for symptomatic stenosis only. And symptomatic stenosis requires a thrombolysis. In case of its failure, we consider stenting, and then again the symptoms already are not as important anymore, and we switch to medication therapy. And that again was Cohen. Despite discouraging finding of recent studies, thrombectomy represents a tremendous progress in the endovascular management of acute ischemic stroke. Probably it will become much safer in the upcoming years. To conclude, atherosclerosis of the vertebral basilar circulation is much less well understood. It's somewhat difficult to do clinical assessment of this patient, and it's more difficult to make a decision regarding indications for revascularization. Contemporary techniques, angioplasty with stenting, expand range of our interventions. Knowing we have to evaluate various portions of both intra and extracranial portions of the vessels. But the correct decisions in this area depends on continuous interdisciplinary collaboration of various specialists, and it's very helpful to have a neurologist, angioneurologist at hand. That's why I'm very grateful to Clinical Hospital 122. Thank you.
Thank you, Professor Soro Cuomo, for this wonderful, interesting speech. I would like to ask you about vertebral stenosis, symptomatic stenosis. It seems to be very rare in Finland to do procedures for this condition, unless in case with thrombosis or thrombolysis. Have you any idea or figures how is the situation in Russia or in St. Petersburg area how common is
With
procedures for this?
thrombectomy.
No, stenting or PTA for vertebral disease, stenosis of vertebral disease.
Intracranial.
Extracranial or intracranial.
Я все-таки буду отвечать по-русски.
I'd like to answer in Russian. In St. Petersburg, the situation with stenting is the following. It's at a very good level of development, but my colleagues and stenting colleagues may say better. Currently, we have at least 5 angioneurological centers, stationary centers. In 4 of them and in 2 large hospitals, there are conditions for stenting angioplasty. It's done very actively on carotid arteries, on vertebral arteries. I don't have statistics now to be precise, but every year this figure is increasing and the number of specialists who can perform these procedures, extra and intracranial procedures in acute period and in non-acute period of stroke. These specialists in St. Petersburg, the number of specialists is increasing.